Okay, so I have two case histories, and they're focused around inhaled corticosteroids. And I think there's been a huge change in the way we think about appropriate use of these inhaled medicines in COPD and the way that we're using them in clinical practice. And this has all been driven by a number of large randomized clinical trials with combination inhalers. I think we're all used to seeing the evidence. The question is, how does this play out in clinical practice? On an individual basis, what should we do when faced with patients who ultimately are all slightly different? When we look at the RCTs, that gives us group data. But of course, in the clinic, we're faced with N equals 1. And that's really what me and Mark will be discussing today. What do we do with every single N equals 1? And they're all completely different to each other. So just briefly, before we get into the meat of the cases, there's my disclosures of interest. So case number 1, and actually this lady I saw back in 2005. She's a memorable COPD patient, and I'm going to jump slightly to the end. She's memorable because when I described to you the state she was in when I first saw her, I don't think as a doctor you would then project forward to 2021 and think she would still be alive, but she is. So here's what's happened to her. When I saw her, she was being looked after by another respiratory consultant in a different hospital who'd managed her for a few years with great difficulty. She had a long smoking history, but she had stopped. And in the other hospital, she had suffered with multiple exacerbations. She'd been ventilated twice. She had numerous admissions for pneumonia episodes. So when I first saw her, one of her big problems was these recurrent infections. She had chronic sputum production between infections. She was on triple therapy, and at that time we had no single inhaler triple therapy, so she was using 2 inhalers, an inhaled corticosteroid long-acting beta agonist combination as one, and a long-acting muscarinic antagonist as another. So investigations supplied to me and repeated in my lab showed an FEV1 of about 35% predicted, so severe COPD. A high-resolution CT scan showed widespread emphysema, no evidence of bronchiectasis. So looking back through her notes, she often grew various bacteria, and one of the most common, both in the stable state and during exacerbations, was Haemophilus influenzae, the non-typable Haemophilus influenzae, NTHI. There had actually also been episodic positive cultures for other bacteria, including once Pseudomonas. But the thing that was a regular pattern was this: NTHI, she seems to be colonized, it seems to be present during episodes of exacerbations. So I'm going to just show you a little bit about NTHI from some papers, and here's one we did, and there's other data like this as well. There is considerable antibiotic resistance for this bacteria. And here are a number of patients in the UK. I must stress that some of this is regional, but you see here that some of the common antibiotics that we use, so macrolides, penicillins, you find that a number of the strains are resistant to NTHI. Now, interestingly, in this sample set, if you were to use something like ciprofloxacin, we had 100% sensitivity. Tetracycline, so obviously doxycycline would fit as well. You've got over 90% sensitivity. So I think one of the things that we need to look at with this extremely common colonizer is careful use of antibiotics, looking carefully at antibiotic sensitivity. And I'd just like you to just remember what you've seen on this slide about macrolides. In this sample set of over 50 patients, you see that about half the strains, maybe 30 to 50% of the strains, are actually resistant to different macrolide antibiotics. Now, another point to bring out about Haemophilus is I've mentioned that it was present in the stable state and during exacerbations. And I think one of the questions that commonly arises from clinicians about bacterial colonization is, what's its relevance? So you have patients who present to you with dirty green sputum. They're in their usual state. So they say, yes, I usually cough up some phlegm. They say, yes, my symptoms are normally like this. So you might think, right, that's normal for them. You take a sputum culture and you grow a bacteria. Is that relevant? What should you do about that bacteria? And I've heard two schools of thought. Some people would say, yes, we should treat it. And other people would say, well, the patient's not ill at this point in time. Maybe that bacteria is there in a small amount, even though we've grown it. Maybe I should leave it, because if I treat it, we're increasing the chances of antibiotic resistance. I'm not saying I agree with that. I've just heard people articulate that view. So I found this study by Tom Wilkinson, who's in the UK, based in Southampton. I found this very interesting. He conducted this very careful study where he sequentially sampled patients, their upper airways, sputum, for the presence of bacteria and viruses. And there seemed to be this interaction between non-typable Haemophilus influenzae, NTHI, and the common cold virus, HRV, human rhinovirus. So if you have a look at this data, if you had both of these present in your airways, and I've circled them, you were far more likely to exacerbate compared to just having the bacteria alone. So have a look at the top. That's NTHI is present, so that's but there's an absence of human rhinovirus. Your odds ratio of exacerbation is 1.69. Now, NTHI is present with HRV, with the virus, a 5-fold increase. Now, that's also represented a bit lower down when you've got an 18-fold increase. And all this is, there's two ways round. One is where something's a colonizer, then the other bug comes in. So the one at the top, NTHI, that comes in second, so it's a secondary infection in the presence of HIV. And the one in the middle is where you have colonizing bacteria and then suddenly you get a cold. Now at the bottom, the rhinovirus alone, then there you've got a 10-fold increase of having an exacerbation. So the interesting one is actually at the top, isn't it? That where you have the bacteria alone, that's actually, it's less than a 2-fold increase in your chance of exacerbating. A virus on its own gives you a 10-fold increase, and both together an 18-fold increase. So actually, this bacteria is sort of laying an unfortunate groundwork in the lungs, so that if you get a virus on top, that's really bad news. So coming back to the question, what should we do about this? And coming back to the case, although this publication is 2017, I think it lays some justification for what I did with this lady, and I focused on eradicating colonizing bacteria from this patient. And this patient, remember, did not have bronchiectasis. So I think it's another thing that's talked about. You have COPD, chronic infection. You should look for bronchiectasis, but you may not find it. But COPD patients can still have chronic bacterial infection, and there's all sorts of pathological mechanisms for that we can get into.
Okay, I just need to stop you here for a moment, Dave. NTHI, not something our microbiologists often report. I can't see my microbiologists report that. So do we have to push our microbiologists to tell us this is NTHI? And what about HRV serology? Is that commonly done in your practice?
Great point. So from standard culture, you can only say it's Haemophilus influenzae.
Okay.
So the serotype B that you referred to is the encapsulated form. So for the encapsulated form, you can type it. So you can do further tests to find out which type you have.
Right.
So non-typable is the non-encapsulated form. So I'm laying it out sort of simply.
Okay.
The non-typable form doesn't seem to cause any problem to most healthy people. So it's the encapsulated form, and that's the one that causes middle ear infections and severe pneumonia. And You're quite right, your microbiologists are quite right. When they do a culture, they'll just tell you it's Haemophilus influenzae. They won't tell you which form.
Okay.
So the way you get at the form is you either have to do a biochemical test, or we did it here by PCR. So we were able to look at the gene structure. Now, in reality, in clinical practice, if you have a COPD patient who has a positive culture from their sputum, I think you can more or less assume it's NTHI, because that's the common pathogen, but some of the encapsulated forms do cause problems. Now, in the end, the practicality of it is that the local microbiologist, if you engage with them, will do the culture, give you the antibiotic sensitivity, and that's actually what you need.
But I saw the resistance was pretty alarming, though. Tetracycline did seem to be okay, 90% sensitivity, and I guess that's reassuring. And what about the rhinovirus? Do you do serology, or do you do a biofire? How do you get that?
Yeah, so that's something that I hope we're in years to come. We'll all have more access to instant diagnostics. So here in the UK, using biofire, that's only available in research centres. So in standard clinical practice, people aren't able to do it. I think at the moment, the best you can do is in the stable state, try and find out who's colonized. And then when they exacerbate, you're left with going off symptoms, and you do standard clinical management. What I'm really getting at here is trying to focus on bacterial presence in the stable state. I think that's the goal.
Sure. Thanks. Mark, do you have anything to add to that on identifying these bacteria and getting to the rhinovirus?
No, I fully agree. I mean, we have the usual culture for bacterial culture, and then we assume that most of the Haemophilus is a non-typable form in adults and in patients with COPD, and we do not have access to the diagnosis for different respiratory viruses in usual clinical practice, only in research projects with PCR. Yeah.
So we do biofires in our patients. They're pretty expensive, but we do have them in clinical practice in Mumbai. Dave, please continue.
Okay, so you mentioned about the antibiotics, and there were two choices here, whether to give something like ciprofloxacin or tetracycline, doxycycline. So I gave a short course, about a month of doxycycline. So short course, but longer than usual, to try and absolutely eradicate the Haemophilus. And so in a way, this was a bit more like the way you would treat a bronchiectasis patient. So a prolonged course of antibiotics. And then she went on to azithromycin. So bearing in mind that, what I showed you just now was that macrolides, there's significant antibiotic resistance for this bacteria. I wasn't necessarily giving this macrolide just as an antibiotic. There's plenty of data that macrolides are anti-inflammatory as well. They seem to have an effect in protecting the epithelial barrier and improving its function. So I was looking at a long-term anti-inflammatory effect with some antibacterial effect, and The interesting thing, going back now 14, 15 years, and I remember this, is how she described that the doxycycline treatment then cleared. It was the prolonged treatment that was the key. For the first time in a while, her chronic sputum production cleared, and it remained so. She's had some exacerbations since, but she's had a marked decrease in frequency. She's never been back to the intensive care unit.
And when you say a long course, you would mean about 10 to 14 days, Dave? Or?
For the doxycycline, I gave her over a month.
Over a month.
Yeah. So a bit like some of the regimes that people use for bronchiectasis, where you would have prolonged antibiotic courses and then maybe switch to another one. So although she doesn't have bronchiectasis, and I'd be interested in Mark's view on this, sometimes you need to treat COPD patients like they have bronchiectasis. And Mark, what's your view?
That's absolutely true. I mean, in fact, we have seen patients with chronic, I don't like to say colonization, with chronic bronchial infection, in which you suspect that they have bronchiectasis, but then on CT scans, you cannot see clear bronchiectasis. But then treatment that we use is the same as if they had bronchiectasis, because the problem, we are not treating the bronchiectasis, we are treating the bacteria. And since this is a chronic bronchial infection, we are treating a chronic bronchial infections either with or without bronchiectasis. The point is that we do not have clinical trials, and what we do is the best of our experience with this, as Dave mentioned, with treatment with tetracyclines in a prolonged time, which is based on common sense and in previous experience with bronchiectasis, but there are no studies on chronic bronchial infection in COPD without bronchiectasis. Probably the only exception is the study by Usun in the Netherlands, in the Lancet Respiratory Medicine, with azithromycin long-term in patients selected for not having bronchiectasis on CT scans. And in fact, they demonstrated that the same regimes as used in bronchiectasis were useful. So that means that probably our approach of treating these patients, even if they don't have bronchiectasis with the same regimes, makes a lot of sense.
And that would be about 100 mg BID doxycycline for over a month, Dave?
So to start with, give the loading dose and then just go 100 milligrams once a day.
Sure. And then once a day, that's fine.
But I think you could use twice a day. Yep. So moving forward, having cleared the infection, the question was how to treat her, and to put it bluntly, how is she still alive? Because 15 years ago, her FEV1 was 35% predicted, and with the best will in the world, most of these patients would not survive 15 years. So she remained on triple therapy. Looking back through her notes, her eosinophil counts blood eosinophil counts, commonly were around 150 to 200 per microliter. That's 0.15 to 0.2, depending on how your lab presents that data to you. Her FEV1 now, she's in her late 60s, is 25% predicted. She's able to walk into the clinic to see me. She has oxygen at home as required. So to use a British phrase, she's no spring chicken. She still has occasional exacerbations, but she is rarely hospitalized, and she actually has something that gives her great pleasure and improves her quality of life. She acts as the primary carer for her grandchildren who are now around 10, two boys who are now around 10 years old. So that gives you an idea that she's actually an active lady, and she's a member of a bowls club. So I think for many patients with COPD, if I was to present you this case back in 2005, somebody who's been ventilated, bacterial infection, FEV1 35%, if I said to you, well, in 15 years time, she'll be bowling and looking after her grandchildren, you'd say this was a miracle. Now, did I do anything amazingly clever? The answer is no. Mark said I had a phrase earlier. He said common sense and standard medical practice. that's all I did. But I think one thing I did that was important is I was optimistic rather than thinking, oh, there's hardly anything we can do here. I think you've got to look, you've got to find things. So I did something simple. I looked at the bacteriology. That was the key. Now, what about her inhaled medicine? And I think it's perhaps fortunate we understand more about eosinophils. So I'm able to say this in 2020, looking back, it's fortunate that I kept her on an inhaled corticosteroid. And I think, in my view, that's one of the reasons she's alive. She has an eosinophil count that is in the range where you would expect some type of benefit from an inhaled corticosteroid. So I'd like to just explain this for a minute or two, because there's been an awful lot of data on blood eosinophils in the last few years. We can't give case histories on inhaled corticosteroids without going into this in some level of detail. I think people get confused with this, so here's my attempt at making it simple. So blood eosinophil counts only have one use in clinical practice with regard to COPD patients. They're a biomarker that will help you predict the effect of inhaled corticosteroids. Now, biomarkers can have a single use in clinical practice. This is important. A biomarker does not have to fulfill multiple purposes. So let me give you an example. We commonly use biomarkers for diagnostics, so cancer diagnostics. But then that's all we use them for. It's for cancer, yes, no, that's it, end of story. So I've heard lots of criticisms of eosinophils because they can't be used in COPD diagnostics. They don't predict when a patient's going to die. And it's true, they can't be used in COPD diagnostics, and they're not predictive of when a patient will die. They only have one use. They tell you the likelihood of the benefit of an inhaled corticosteroid. So I think that's important. So therefore, you only use blood eosinophils for this purpose in people who have a history of exacerbations. That's the second point. Now, in these patients, this graph's a simplification. It could easily have said triple therapy versus dual bronchodilator. There is no magic single number. So come back to cancer diagnostics. For diagnostics, you want one single threshold. And you want to say above this, cancer, yes, below this, no. Drug responses in human beings are not so simple. You know this from clinical medicine. You give any drug, what happens? Some people will have no response. Some people will have a small benefit. Then some people will have a big benefit. So you have this spectrum of responses. And what blood eosinophils do is they beautifully help you predict where on the spectrum an individual patient will lie. It's not perfect. You use it with clinical information, that's important, and you put the two together, and it's one of the pieces of the puzzle that helps you make your decision what to do. So the important numbers, and these are just approximations. Remember, there are no strict thresholds. So when you talk to physicians who get really worried, and the numbers I'm going to talk about are 100 and 300. Some physicians get really worried that they read a paper that blood eosinophil counts can go above or below these thresholds. This is not a problem. So if a blood eosinophil count one day is 320 and the next day is 280, it doesn't matter, because these thresholds are just approximations. So at around 100 eosinophils, below this, most patients do not respond to corticosteroids. And actually, below this, you find that many of those patients are the ones with the worst bacterial colonization. Now, above 100, that's when you have more of a probability of corticosteroid response, and the higher the number, the bigger the response is likely to be. So the number 300 is just a randomly plucked out number at which you're more likely to see a big response. It's a nice round number. We could have used 250, you could have used 350. It doesn't matter. The likelihood of response at 250 and 350 is pretty similar, and that's why it's not worth worrying about. So just to summarize that eosinophil section, I think the point I wanted to make really was that with her eosinophil count in that range of around 200, we would have expected a benefit of inhaled corticosteroids. And that plays into the triple therapy studies. I'm showing you the IMPACT study. I could equally have shown you the ETHOS study, which has highly similar results. IMPACT has 10,000 patients. ETHOS has 8,000 patients. They both studied triple therapy versus double combinations. I'm going to focus on triple therapy versus dual bronchodilator. And so that's really where you understand the corticosteroid effect. And they both showed, as predefined endpoints, not post hoc analyses, they both showed advantages in terms of all-cause mortality for triple therapy.
Fascinating case, Dave. Fascinating. Thank you so much.